Hello, everyone. Welcome to Teddy Talks, a podcast created by UCL Paediatric Society, where medicine meets mischief and we discuss all things pediatrics, from teddies to training pathways. I'm Yameena, one of your co-hosts, and I'm currently in my second year of medical student.
I'm Laetisha, your other co-host, and a fifth-year medical student. We're so excited to finally be able to launch this project and explore pediatrics together. We're bringing you along with us as we We're bringing you along with us as we dip our toes into the vast array of subspecialties in pediatrics. If you're a medical student or anyone interested in pediatrics but don't know where to start, just like us, then you're in the right place.
So, in our last episode, we were really lucky to have Dr. Keir Shields on the show to discuss his life within general pediatrics. We had some really amazing conversations on different routes into medicine, the ability to develop special interests even within general pediatrics, neurodivergence and decentering medicine, and balancing other experiences in your life. It was a really reassuring episode for those of you who are scared by peds competition ratios, and it's definitely one to listen out for.
Yes. But today, we're going to be focusing on a specialty that I don't think we get a lot of exposure in medical school, despite its clearly critical role in children's development, which is community pediatrics. So on today's show, I'm honored to welcome Dr. Ella Rachamim, a community pediatrician based in London, mother of 3, including identical twins, and founder of Be Ready to Parent, a practical training initiative for both parents and professionals. Alongside her work in community pediatrics, Dr. Ella is a pioneer for mental health advocacy, particularly for women experiencing perinatal and postnatal depression. She has co-authored Be Ready to Parent Twins, Pregnancy and the First Year, which offers guidance and perspective for parents of multiples. She is also the safeguarding lead for a charity run by UCL medical students called Spectrum, which offers a befriending service to children under 18 with disabilities or special needs in the Camden Borough. So, Dr. Ella, welcome to the show.
Thank you. What a great introduction. That's lovely. Thank you very much.
Thank you so much for being here. So, as always, we love to just start off and set the scene by asking, what does community pediatrics involve? I think community pediatrics is a field that I would say is not as well known amongst medical students today. What would a usual week look like for you? I know that's a bit of an impossible question, but what made you choose this subspecialty specifically, and how was your journey getting there?
So you're right. I don't think it's that well known in medical students. I actually sometimes don't think it's that well known even in junior, with junior doctors or junior pediatricians, because unfortunately your exposure to do a specific block doesn't really happen maybe until your third or fourth year of pediatrics, and it's not a compulsory statutory block. So it used to be, but now it isn't. So I don't think a lot of people get exposure necessarily, so then they don't really know what it is, so then they don't know if they don't know what they're missing, basically. So I think it's not just medical students. I mean, I was probably a slight exception in the medical student years, because I always had worked with children with disabilities since I was about 15, and then like Laetisha said, I was involved with Spectrum, which links students with children and with special needs in Camden, and I was very, very involved in that charity at UCL. So I kind of always was thinking that I would go into pediatrics, and I probably was always going to go into some aspect of child development, neurodisability, children with special needs. But I think that most people don't have that. Most people kind of sort of bumble across into community pediatrics and then realize what it is and what they like about it. But I do worry that a lot of people are not getting the exposure to it, and so then they never know what they're missing.
Mm-hmm.
But yeah, my week, it's a bit, so the nice thing about community pediatrics is that you've got quite a few, it's a subspecialty of pediatrics, but then within it, there's so many different little subspecialties within it as well. So we all have like a bit of a lead in our department. So you might have somebody who's very much taking the children and young people, caring for them that have really complex neurodisability, very complex needs, and maybe very profound learning disability, profound physical disabilities. And we visit those students in their special schools. So we do a lot of outreach work. We visit a lot of the special schools in the borough that I'm in. So I'm in Barnet. which is brilliant because it's very multidisciplinary. The student doesn't have to miss school. You get to see how they're doing in school. The parents come, the therapists come. So I love that aspect, and I get to know the families with profound disabilities who are going to be really on our caseload their whole paediatric life. I'll know them maybe even from infancy or adult, early childhood right the way through to 19, which is something I really wanted. I think that was my real positive of community paediatrics, that I get to know this family and we go on a journey kind of together. And then you will have looked after children, so children that are in care, that comes under community paediatrics as well. We have a designated lead for looked after children. She also covers adoption and fostering, so children that are adopted need to have certain medicals done, development assessments. Any child that goes into care will also come under community paediatrics for initial health assessments, and that's one big aspect. We also often cover safeguarding, so there'll usually be a named doctor for safeguarding that comes from community, and we're often part of the rota for the child protection with our registrars as well. And then I also do, part of what I was doing today is that I'm the lead for child death. So there's a statutory role for a paediatrician that has to review every child death in the borough, and one of us takes that lead. So I'm the lead for Barnet Community, and we have to review what happened and why it happened, and whether there were any learning from it, recommendations, and if there were any safeguarding issues. So that's another role. And then the other big role we have is around EHCPs, which is like children that have special needs who might need educational support and educational health care plan. So we submit medical advice to that to support children in schools that might need extra educational input. We have a medical role there. And then on top of all that, our general day-to-day, which is often why we have quite a long waiting list, is our child development clinic. So children get referred to us for delayed development. It could be in speech and language, or speech and language and mobility, or social communication delay, or general delay. Can be behavioural things as well, but generally our biggest referral is probably worries around the age of 2 or 3 with a child that's not maybe socially behaving as you would expect, or developing as you would expect socially and in terms of language, and that would come to us as well. So we see a lot of the child development team, all that kind of thing, and also children who need regular reviews, such as Down syndrome. So that also, I'm the lead for Down syndrome in Barnet as well. So most young people with Down syndrome will always get a medical review once a year at least. So I kind of cover that as well. So lots of diversity, which is brilliant, but then it's a massive workload.
Yeah, I can imagine.
It's a really impressive portfolio, yeah.
Yeah, I feel like one of the interesting things that you brought up there was that you do a lot of outreach and going to schools and things. That sounds very interesting. But I think one of the things that we were thinking about was also what was the effect of the pandemic and the lockdown on that, because obviously your work sounds like it's involving a lot of in-person time and a lot of collaboration with parents, with families. How did the pandemic change that?
It's
well, I mean, the
schools, you're right. So the schools shut. So for a while, all the schools were shut. So we were not allowed to see them in the schools, and we were not allowed to see them because they were well children who were kept at home at that point. So we converted everything to telephone appointments. So everyone that was due a review, we were still working. We still sort of did telephone, and we had video platforms as well. It wasn't ideal. So as I said, if I'm looking after a child that's got quite severe cerebral palsy, I need to examine that child. I need to check their tone and their muscle ranges, and how their weight, what's their weight doing, and all these other things. So I found it very uncomfortable, if I'm honest. And as soon as I was allowed, I broke the rules and went back to doing physicals, because it didn't really sit very right with me. But thankfully, as you know, with COVID, it didn't really, it didn't actually affect young people. So regardless of how, vulnerable my patients are, they all remained very, very well, which is great, because they didn't have to get admitted. So we don't know what it was about COVID, but that was a positive. None of them got sick. I think it caused issues with safeguarding as well. We're safeguarding as well. We can't see the children. So when you can't see the children, there's always those issues, missing appointments, and just not being able to kind of see the children visually was quite difficult for us, but also the schools. I think the schools felt very isolated, and they were trying to do as much as they could, but it was difficult. I think children went unseen, and that was quite hard. But yeah, I mean, thankfully they remained well. But I don't like the video. I don't mind video follow-ups, but I don't really like it for the initial assessment. I feel like I need to see them in person.
Yeah, of course. How effective did you think that was during the time? Did you run into a lot of problems at all with that?
Well, the IT was horrendous, so yes. I mean, we went from having no real system to suddenly be doing everything online. It was like, and then we didn't really have the IT backup, and we were also having paper files at the time. We weren't fully digital. So I'm having somebody send the notes across for the clinic to my home, and then disinfect the notes or whatever. I mean, I didn't really like it suddenly became like this. It was just new, like. Before the pandemic, people didn't think doctors would work at home. I think that was the issue. They didn't let you do virtual clinics. They didn't let you have laptops and blah, blah, blah. I think they thought that we wouldn't do the work, and actually they could see afterwards that we did do the work. So actually some people now still do a lot of virtual follow-ups and, telephone calls, which is absolutely fine for that particular team. But yeah, it wasn't like we were set up properly. We had very poor IT interface. It was not easy, but parents could access us. We were very accessible to any parents that needed us through our team, through our office, and we still kept up some of our meetings with the rest of the multidisciplinary teams. I think one of the big things we faced was kind of going back to school afterwards, because parents were really scared, and so at what point do you say, well, actually you have to go back to school now, and then what point is it a worry or not a worry? That was quite difficult. Parents were quite reluctant to come back, and I understood that, but it got to the point where actually they had to go back to school. So that was an issue. I remember people asked me about whether the COVID and the pandemic and meant that we're now having an increased referrals, because obviously I'm talking about the special schools and neurodisability and that area, which is mostly my niche. But of course I do a lot of child development clinics where we're getting children coming through generally for autism assessments. That's a huge, that's the biggest referral. That's our huge cohort, and we have a massive waiting list. Do we think COVID increased autism or increased referral? I don't know. I mean, I don't know if we know yet, but I mean, we definitely had a massive rise in referrals after. We had and also we had the backlog because we couldn't do the assessments in person. We couldn't do the autism. Sometimes we need to do an autism observation. We couldn't do that. So there was this huge backlog on top of the fact that I think the referrals dramatically increased. Yes, they did increase. And do we know if that's because they didn't socialize? I don't know if we know all of that yet. I just know that the workload definitely went up after the pandemic, and they weren't seen, so they didn't get their 2-year checks. So now they were presented later. So the health visitors normally does a 2-year check. Some of those were missed, so they're presenting later. So and then the backlog. So yeah, we haven't caught up. We just the waiting list has got bigger and bigger.
I see. For our next question, we just wanted. I think we're going to shift the topic a little bit to a specific group of children, which is the group that you actually mentioned, children with autism. In the previous episode, we were looking into this as well with Dr. Keir Shields, and we were speaking with him about how autism is called autism spectrum disorder, which means that it lies in a spectrum, and we're talking about how autism lies. We can think about it as how autism kind of lies in the same spectrum as people who we consider to be neurotypical.
Neurotypical, yeah.
And so our question to you is, why have we stopped using the terms high functioning and Asperger's, and what does the spectrum mean in autism spectrum disorders?
Yeah, no, it's a good question. And it's obviously the main question parents ask. As soon as you diagnose autism, I guarantee you the next question is, but where are they on the spectrum, Dr. Ella? Because they want to know whether they're kind of fitting the normal, typical, could they go to mainstream, are they high functioning? That's what they want to know. They've heard of the word spectrum and they don't quite know what it means, but they'll say, Dr. Ella, where is my child on the spectrum? So what we've tried to do over since I 20 years ago I started. This is more in the last few years. We've kind of changing the way we kind of use the word spectrum and kind of describe it. So in the olden days, we would kind of use this word high functioning or Asperger's. So high functioning or Asperger's would be like your young person with autism that is very intellectual, right? So that they've got like good levels, very high levels of cognition. They don't have language impairment. They usually would go to mainstream. And that's what they would, and people go, oh yeah, Mozart probably had that, and Einstein and all these clever people. But generally it's kind of, that's what people sort of felt when they were talking about that. Whereas low functioning, you probably meaning the child that's non-verbal, who has quite significant cognitive or intellectual impairment, who may need a lot of educational input or a special environment. So that's the kind of extremes of the spectrum, which is they used to use as a bell curve. I think over time, and I believe this, I think it's not really that helpful actually to the high functioning end, because you can be very high functioning. So you can be very, you can have normal levels of language and cognition. But if you have autism, you can still have a lot of real differences and difficulties that mean that you are going to struggle. So you can have a lot of anxiety, you can have a lot of sensory processing difficulties and needs. So you're in that class and it is overwhelming because it's loud and stuffy and noisy and things are unpredictable and you need predictability, and your anxiety is just escalating and escalating. And then you might mask it because you want to be the same as everybody else in the class. So you mask it, you don't show it, and then you burst at home. You kind of have a huge outburst. So what happens at home might be very different to school. And I think that by using the word high functioning, I think we almost take away that they can still have difficulties and differences. So I don't like to use it in that way. I kind of use something called the autism wheel, which is looking at every individual symptom of autism or difference, and then thinking, where are you on that spectrum of anxiety? Where are you on that spectrum of social interaction? Where are you on that spectrum of sensory processing? Where are you on that bit of language difficulties? And each thing is really important, because you might have some children that are even more debilitated maybe by their sensory difficulties and their anxiety. And there may be another child who's lower functioning with cognitive impairment. So it kind of, it's not that does that make sense? It just feels a bit more helpful to do it like that.
Absolutely. I think it's really interesting. I mean, we had this conversation before about how people living with disabilities, rather than, redefining it as to mean that there's not an issue with the person themselves, rather they're disabled by their environment. So I think it's really interesting that you brought up that again, because it's a very recurring theme. I think it's come up a few episodes now, and it's really, I think it's really powerful that it keeps coming up as well as a concept. So again, on a similar vein, we know that in your medical school days, you were involved with Spectrum, which gave you a more personal exposure to the complexities of caring and supporting children with disabilities and the experiences of their families. What did you learn from that experience as a medical student, and how has it shaped your practice?
Well, I went into it with children with disabilities, so I guess it did something. I was involved before Spectrum, so I kind of was involved with a charity for children with special needs. I used to work in a care home and used to work in a summer camp. So Spectrum for me was quite obvious, like you say, was in Freshers Week. I was like, oh, I'm going to go and do that. So I started doing that, and then I think in year 3 I became the chair of Spectrum, and then carried on. So actually I had the same family the whole time, so that was kind of beautiful as well, and I'm still in touch with that family. So it probably wasn't the norm for Spectrum, in that I wouldn't expect everybody to start Spectrum to be with the same family for the next 20 years of their life. But for me, that kind of was really, they're like so important to me that I always kind of felt it was going to be the area that I was really going to go into and kind of focus on. I knew I would do something with disability. I kind of I went off in a direction of infectious diseases for a while, and worked abroad in the Gambia and other places for a bit, and I kind of wanted to do that. But I think when I came back to the UK, it was always going to be around something to do with disability. Just yeah. So there wasn't really, I knew I wanted to do paediatrics. I don't think anything else was that interesting.
I think I resonate with that. From my experience with Spectrum, I also have become more and more fond of pediatrics and just working with the children, working with the families. It's really opened my eyes to all of the little things that we don't really think about as medical students. Because, in medical school, kind of just in the hospital, we see the doctor, we see a patient for like 2 minutes, clerk them, and then leave. But then in Spectrum, I get to be with a child and their family for years, and you kind of get to see the little things that happen in their life that they're struggling with, the things that are quite like beautiful progressions, and it's really wonderful to see. And that's what
I mean, it's
Such a
great
beautiful
that I
pediatrics
have
kind of
perspective.
around that lane as well.
yeah, because these families are with me for years, and it's quite a big deal
Yeah.
when, I mean, it's quite upsetting when you have, you cut off, because we do cut off at 18, 19. And that's a big worry for the parents. The parents have this anxiety from like 14, or when are you going to discharge us, Dr. Ella, or whoever it is, because they know that this is coming. And unfortunately, there isn't an equivalent of community paediatrician in adulthood. So they know that. They know that, and they're very anxious by that. I don't have the answers, but I know that it's not ideal. We work really hard on transition where I am now, because it is such a big fall. Well, they feel like it's a big fall, but we try really, really hard to make it as smooth as possible. And we're working really hard on that transition. And it is a lot better than it used to be, but I know that they feel very contained in community paediatrics, and then they sort of feel slightly lost.
Yeah.
And a lot of these young people are now moving into adulthood. They may not have survived before, so now they are. So we haven't really got that. We haven't moved forward with creating a physician for 18 plus,
Yeah.
So it's a gap. It's a gap that's going to get bigger, because the young people are surviving, really long term, with all the gene therapy and all the great medical care. And I don't know, there has to be a new role that is going to suddenly, there has to be a role that will develop, because at some point.
Definitely agree. From what you've been telling us as well, from the beginning about everything about community pediatrics, I think we've kind of established how complex and just how multifaceted, like managing and supporting children with neurodevelopmental differences and special educational need. And so we were wondering if you can tell us a little bit about that MDT, the multidisciplinary nature of community pediatrics, and what services do you liaise with to support your patients, and just can you describe to us just how that collaboration looks like?
So they may, like when they first come to the clinic, there may just be me and the family, but you may also have some clinics where it's joint. So like if, for example, it's a new referral that sounds like it's a motor disorder or movement disorder, then I would always do that initial assessment with the physiotherapist. And then some of our patients who seem very complex, so when their referral comes in, we have a multidisciplinary triage, which I think is a really good model. So at that triage, the referral comes in and we go, okay, that also will need physio, OT, speech therapy, whatever. So they all get a referral at the same point. So sometimes we have one clinic where we might see very complex children with some other therapists and the education team, so preschool teachers. Sometimes it's on our own, and sometimes it's just with the physio. When I see children with Down syndrome, I generally see them now with the therapist who leads on dysphagia, because some of them have quite a lot of aspiration and difficulties with swallowing and the risk of aspiration. So I tend to do a clinic now with the feeding team, which is really, really good. And then the school reviews are always if they're in a special school and still under us, so we don't see everyone in the special school, but if the young person's under us, I would always do that clinic with special school nurses who accompany me. And then sometimes I have a teacher, and then sometimes I have a physio that joins as well. And then we see the parent and we do all the parent stuff, and then we bring the student in and see the student together. So that's multidisciplinary. And then the child protection is going to be involving any child protection work, and on safeguarding or anything will always involve social care. So children's social care, and also often the police. So the Kate team within the police. So we have contacts quite closely with them. Yeah, I mean, it could be really vast. I mean, if I have a very, very complex child with really quite profound neurodisability, they may well be under 10 different specialties at Great Ormond Street Hospital. on top of me trying to be that kind of continuation, and that I feel like I contain it sometimes, because the specialist will see one part of the body. They may see the spine, or someone else will see the eyes, and someone else will see the gastrostomy. But I'm trying to like link everything together holistically, but also looking at the family and the siblings and the home and the housing and the social care support and the psychological support and the spiritual support, and kind of thinking about all of those things. So it's not just the spine, which is what generally happens when you're a specialist. So I see my role quite a lot as a general paediatrician, but also developmental paediatrician. But a lot of it is advocacy. I think you said that right at the beginning. Like, I feel like it wasn't necessarily what I thought it would be, or when I was in medical school, did I think that I would be doing a lot of advocacy? Probably not. And am I the right person to do it? I don't know. The jury's out. But that is what I do a lot of, trying to make sure they get their right benefits and their blue badge, and their housing needs are huge sometimes, equipment needs, wheelchairs, just that advocacy role is big and probably underestimated in terms of our job descriptions, job roles and planning. We kind of seem to be that main link to supporting this family from an advocacy point of view.
I love how multifaceted that response was. I think it's so interesting because, I mean, again, this is a phrase that's come up a lot, the idea that it does take a village to raise a child. And the fact that the community pediatrician has to be involved and as involved in every kind of part of that village, I think it's a really, it must be such a rewarding place to be, and obviously a huge responsibility, but really incredible one. I think it's astonishing how community pediatrics isn't very well known, considering how
I don't know.
involved you guys are. I think
know.
so. Yeah, absolutely.
I don't know. I mean, I think people just think it happens by magic. I don't know what they think. I mean, I don't know. We're really
Yeah.
busy out there, and
Mm,
sometimes you're quite surprised that they don't know about
yeah.
you, or
Mm,
but the families are that, they're brilliant. They're amazing. I mean, these
mm,
families have so much that they have to do, and there's so many,
yeah.
often so many appointments, so much paperwork. One form for disability living
Mm,
allowance is like 50 pages long.
yeah.
These families have a lot, and I'm not saying I'm the only person involved. We work as a team. There's lots of us here that kind of doing it.
Mm,
It's just to remind, these families have a lot to do. Things are not made easy for them,
mm,
and it has to be renewed, and they have just so much paperwork to fill in that often feels
yeah.
quite unnecessary.
Mm,
They have a lot of appointments, and we're not great at kind of trying to maybe put those appointments together on the same day or something like that to support them. It's difficult, and then they
mm,
got to get transport, and then it's much harder than people think, I think.
yeah.
So we do advocate a lot. We do write a lot of supporting letters for our families. We do try and we book appointments that we think they've missed, and we try
Mm,
to we do a lot of supporting letters. We do kind of chair a lot of professionals meetings to see if we can get better support for these families. And I
absolutely.
think kind of that connecting up with all the services, like you say, but also just thinking about the family. I've had a family where I have one child, but then it turns out that the younger two have also been referred into the child development team because they're
Mm,
delayed. And actually it's just thinking outside the box. Well, actually, like, let me now see the other two, because then
mm,
you've got one paediatrician for the whole family, and then me
yeah.
linking up to social care. And I think we all try and do that. It might be a bit harder in the hospital. We think very holistically, I think.
Absolutely. I think one of the main difficulties with managing and supporting children with, neurodevelopmental differences or special educational needs could be the waiting time. That's come up quite a bit, to be seen by a CAM specialist for assessment or by a community pediatrician for management after diagnosis. I mean, there are waiting times to access services such as SALT and dietitians. What do you think can be done at the primary care level and community level to support families whilst they're on the waiting list?
That's a very good question. Did I give you that question? That's a very good question. I mean, it's really upsetting, I've got to say. I think people
Yeah.
don't realise that, we don't like the waiting list being
Mm,
120 weeks, which I think it is now. I mean, it's just ridiculous, and it's actually very
mm,
depressing. So, the people that are left waiting, I know that being on the list is not great, but I just want to say, we don't like it either. Some of my colleagues almost want to leave because they feel like they're missing the boat for early intervention. They're not seeing the children when we know in autism, we know in these things we need early intervention, but if you're not seeing them for 2 years, and then you kind of have even less of a workforce because they've gone off. So it's it is very difficult, and it's not what we want, and we are working really, really hard. I think part of the problem, I was talking to the line manager the other day, is that we have so many of these statutory roles that have to take priority. So child protection, child death, looked after children, EHCP work. There's less workforce that's seeing just your child development clinic work that's coming in with all these new referrals. And I think so staffing is massive. We haven't got enough staff. We probably haven't got enough people interested in community paediatrics, and then they're not going into the field, or they're not exposed to the field, so therefore they don't apply for the jobs. But what do you do on the waiting list is an issue, because they will wait for 2 years. For us, they might wait 2 years for CAMS, they might wait several months for speech therapy. Well, I think they just, and then the GP's kind of left waiting, because they kind of say, well, I've made the referral, but actually, in that 2 years, they're still having to hold the family's hand and point them to the right direction for support. There's actually quite a lot of hubs now that seem to be developing, so like parenting hubs or autism hubs, and I think like this kind of new model of like neighborhood care, and they seem really good because they're very good at like accessing, sort of giving you resources and information, and also putting you in touch with various local organizations, and they seem to be now accepting without a diagnosis. The problem before was it was very like diagnostic led, but now I think services, because they know waiting times are long, they will say even if you're on a waiting list for an autism assessment, you can still access the autism hub or the parenting hub or whatever it is. I think there is a move to give that early support. It might not be therapy or intervention, but at least early support to the family. It could be on sleep, could be on eating, could be on getting the right disability allowance, those kind of things. I think there is more of that available now, which is really, really good. But we just can't keep up. I don't know what the solution is.
Yeah. I feel like it sounds quite overwhelming with like all of the waiting times, especially when you said these children require like interface with so many different specialties, and there are just so many different waiting times. Yeah, along that line, considering the publication of the NHS 10-year plan this summer, that outlined the movement of healthcare from the hospital to the community, which maybe could be a solution, maybe not. So can you detail what your hopes are for this, for the community pediatrics, and just potentially any concerns that you have about this plan?
I mean, I love the idea, if it came to fruition, it sounds great, but I think we have to be realistic. If you've got a certain pot of money, it always will go on acute care. It will always, the priority is always A&E, and the emergency team and the throughput from hospital. Realistically, you can't just say, oh, we're going to move the money into community, but the priority is always the hospital, the A&E, basically the ED and that kind of service, and then you're kind of left with the rest. So we just need more staff. That's what it is. It comes down to staffing. There's just not enough physical people on seats to see the number of children that we're being referred. And I don't know if that's about not having enough money for these people, or that there's not enough staff applying. It's just physically, it used to be money, it used to be resource. Now it's just staff. There is just not enough of a workforce, so we cannot see this number of children. We're getting more referrals in than we physically can see a month, so there's always a backlog. And the same with speech therapy. And on top of that, the referral rate went up. It has gone up. There's no way around that. So for whatever reason that the referral rate has gone up, whether it was COVID, I don't think it's just COVID. I don't know. We don't know why there's a rise in autism, ADHD. We don't know. But at the end of the day, there's a massive rise in assessments, or what people wanting assessments and a diagnosis, and we haven't built the workforce for this level of population. So that's where we are. I don't know what they're planning to do, but we were not built for this level of referral. So I think, from a paediatrics perspective, I think one of the things you said from the beginning, there's just not enough exposure. So I'm finding that, if you don't know about it, then how are you going to go into it? So, we see registrars at ST4, they might come and do a placement with us. They've never had exposure to community paediatrics, ST5, but they've already decided, I want to do hematology, oncology, or I want to do cardiology, or I want to be neonatal. And they've kind of decided without ever having a community block. So there is a shortage of community paediatricians who actually people who are actually applying to community paediatrics. That is for sure. I assume it's exposure. I didn't know if it was also maybe a worry about child protection. There's been some big cases, Baby P, Victoria Climbia. Did that put people off? Because they do associate community peds with the child protection rota and safeguarding, and I don't know if that put them off. It never put me off, so I don't really know. I'm not in their shoes. I think they're not getting the exposure. I did an SHO job from my third year. If I had so much exposure, but they don't have to do that anymore. So I worry that they get to like ST5 and then onwards, they've already made their choice. So I don't know how. I think we need to change it. I think they should have to do some community placements as like an ST 3, 2, 3, something like that, where you still do your on calls. I mean, I was still doing on calls and nights, so we qualify as general paediatricians. But, doing a block of community is really important, because I think it will move. Children are generally getting, is there a word called weller? But, healthier and better, and we have amazing medication. And, these children are now more out of hospital than in hospital, and with AI and everything like that, I do think the community element is going to be bigger, because we're having very, very complex children who've had gene therapy for their SMA or whatever it is, they are surviving, and they're having amazing medical treatments and interventions, and so they're out of hospital and they need to be looked after in the community because they're out of hospital. So it's a good plan, but I don't know whether it will come to financial fruition.
Yeah, absolutely. Now we're taking a little bit of a shift. I mean, another hot topic, I think, at the moment, and something that I think is finally kind of getting its time to be spoken about, is adverse childhood experiences. And there is a clear link between adverse childhood experiences and a child's development and long-term mental health and even physical health. And adverse childhood experiences could cause children to learn to react to situations in different ways. For example, they might get overstimulated or overwhelmed easily, or they might find it difficult to express that distress they might feel, which might manifest into something that looks like a tantrum or something similar. Now, these behaviors can be quite similar to what we see in autistic children. How do you navigate around these kind of diagnostic uncertainties, and what is the best way forward in supporting and managing these children?
And it's a really, really good question. In fact, it's such a good question that we often debate this in our team, even now. We actually discussed it only last week. We had some safeguarding supervision and peer review, and this was exactly the question that came up, because, you've got a child who's presenting, like you say, with what we think looks like autistic traits or autistic features, which might be emotional, could be dysregulation, right? So they have dysregulation, meltdowns, that kind of thing. And, is it because they have autism, or is it because they had an adverse childhood experience, or they learnt this behavior, or they didn't, whatever happened in their early childhood. So yeah, it's very topical, I would say. And then, we're not sure, actually, to be honest, should we because what you want to do is you want to get that child the maximum support. At the end of the day, for me, I'm like, what is the goal here? So the goal is to get support for this child, regardless of diagnosis or label. The problem is some of the services, as I said, some don't take a child without a diagnosis. So, for example, if you've got a specific training program, let's say that we've got most children have a diagnosis of autism before they go to school. Will have can have access to specific autism therapy, so specific autism teachers that come to the home and come to nursery, and they do one-on-one therapy, can play therapy, learn, really supporting this family and the child, specifically autism trained. But they will not you cannot refer without a diagnosis of autism. So we are like sitting there in clinic, in our team meeting, thinking, well, you know, this 4-year-old or this 3-year-old, if we gave them the diagnosis of autism, they'd be able to access our amazing autism teaching provision with therapy and parenting courses. But do they really have autism, or is it because they haven't had the right, you know, they've had those adverse upbringing, childhood experiences, parenting difficulties, you know, different foster carers, whatever it is, you know, and that's really difficult, right? Because I want just the maximum support. It isn't easy, and we kind of have like little discussions in our group because we don't want to over label. At the same time, I really want that person to get support. So we recently actually are doing something where one of our speech therapists who's really interested in this area, she's trying to speak to our autism pathway and our autism teachers to say, well, you know, could you have a group of, you know, we've got a few children like this, would you still consider giving them that access to that therapy and that support, even though they don't have a diagnosis yet? And we're kind of in those discussions, but there may be other boroughs that have like a psychologist that can kind of hold that group, or there may be a particular part of CAMS or a particular part of social care that kind of hold that group. Barnet, at the moment, we've identified this gap where we can't get them support without the diagnosis, but we're not happy to give the diagnosis because we think it's related to well, we haven't unraveled the childhood experiences yet, because they may still have autism. Remember, you can have ACEs and autism, or ACEs without autism. So, you know, they may well have autism, and whether that was caused by early childhood experiences or genetics or environment, we don't know. But we just don't want them to not get support because we're sitting on the fence still, you know. So yeah, so we are definitely aware of it. We're looking into it. We realise the complications, and it's just, you know, it's a discussion point we take really seriously in my team. We're hoping that we might get some sort of exception to the rule here. That's where we're looking at. We also do get second opinions from Great Ormond Street. So sometimes when we're not sure, and we've done all of our assessments, we've got some really amazing speech therapists that work with us that do the ADOS, the autism assessments and autism schedule. And you've got all these kind of features and you're not sure because you've got this history in the background of trauma, let's say. We might then ask for a second opinion from Great Ormond Street. You have a neurodisability service there to get a really good thorough assessment from them as well, and that can be really helpful. But yeah, it's a really good question. It's a group that we kind of are a little bit worried about. Not quite no, but hopefully have some good news for soon.
Hopefully.
Yeah, I had a child recently where this came up, because I was actually amazed with how different he was. He was so different within 3 or 4 months of being with the other parent to the parent he was with. So when they first presented, it was query autism. Does this child have autism? And honestly, it was very barn door clear that he looked very autistic. You know, he had a lot of autistic traits and features, and I could have diagnosed, but because I knew the history of, there was a lot of social care involvement, a lot of concerns about mum's bonding. She really struggled with bonding with the baby. Lots of issues. I didn't take a diagnosis and I left it. And I said, let's wait. And I referred to our assessment team to keep an eye on him and to do another assessment. And then down the line, about when they went to court, and then he moved to the other parent. And honestly, within 3 months, I saw him and I thought, apart from some language delay, he looked like a completely typical child. So there you go. So it was quite amazing, really.
I feel like we keep coming back to this theme of kind of like waiting times and like getting that access to help. Hopefully we figure out something that could help these children when they're kind of like in that gray area that we've just been describing all episode.
Yeah.
No,
I agree.
But with him, even now, 20 years, I've been doing it for 20 years, you know, I was so surprised with how quick he changed. And I thought that was so positive, because it means that, you know, that when they are young, you know, they are really, their brains are plastic, right? So they are adapted. You know, I know that maybe he might not be everyone, but I was just really positive to see like how well he'd done within such a short space of time, when all the environment and the nurturing and the love and everything was aligned, and it was just really nice. So it was a positive.
Yeah. I think what was really interesting from what we've spoken about is that pediatrics itself is such a young specialty. And I think that when we were talking about there needs to be that kind of branch post peds, like into adulthood, I'm thinking so much about like what the future of pediatrics look like in that sense as well. Yeah.
That would where I would go. I'd love to extend to 25 or something like that. But, as you see, we're already so stretched that would not be possible.
Yeah.
There
Yeah.
has to be this gap because, you can't, and it's difficult. These young people are used to being pediatrics, and then they're now on adult wards with adult physicians, and it's, there will be a role at some point, but I don't know if it will be a doctor role or a key worker role or something, but yeah.
Yeah, hopefully.
Absolutely.
So our next question is about your project that we were mentioning earlier. We were wondering if you could tell us a little bit about that project called Be Ready to Parent. So what is it, and what brought you to start it?
Yeah, so I'm not as involved. I'm not really as involved now with it than I was. So what I did was I actually had several years out of medicine after I had 3 children, as you mentioned. They were very close together. So I had 3 under 16 months. And at some point I stopped medicine for a few years. And during that time, I started this company up called Be Ready to Parent, but I was at home with the kids. And it basically just sort of grew from antenatal classes, first aid courses, working very much with twin mums who, mums of multiples are much more, their risk of postnatal depression and things like that is actually doubled. So it kind of became like support groups around that, twins support groups. I got very involved with the sort of mother scene. And then I had another friend who was a mum of twins, and what the twins group did is they sort of buddied you up. So I was like a mum of twins, and they buddied me up with this mum who was pregnant. And then we just got on very well. And she said, Ella, we should write a book. So we wrote that over about 4 years of meeting every Monday night, because the rest of the time we were busy working and, with kids. But we managed to get this book out, and it really just put all our heart and soul into everything that we felt we would wish we'd known, or kind of. So it's a very practical book, what to do when your multiples are just born, a lot around feeding, a lot around sleep, a lot around your mental health. And it's divided into like different ages and those topics. And we spoke to lots of parents as well. We interviewed other parents, so they've got like their tips and strategies and things like that. So that was part of it, but the big part was like running courses, and courses for like people like childminders and things like that. They actually really want to know more medical stuff. They're very interested in learning about breastfeeding or about twins or about reflux and allergies. So we kind of ran pediatric focus days for anyone that really wanted it in the child sector. So it worked very well. And then about 4 or 5 years after, I got asked to come back, and it was meant to be 1 day a week, but now I'm almost full time, so I can't do both. So I said yes to 1 day, and slowly it's gone up and up and up, and the Be Ready to Parent has gone down and down and down.
But it sounds like an amazing project, and I think that really links nicely to our next and final question, which is that I feel like one of the things that's at least one of the more difficult things for us medical students to understand is what it feels like to be a parent. And I think in pediatrics, I mean, in our conversations, we often talk about how the most difficult part of the consultation is kind of addressing the parents' concerns and worries and needs, because for parents, there's a lot of emotion involved when it comes to the health of their child. And that's sometimes why, we struggle, or we're a little bit scared of having those conversations. So do you have any advice for medical students or even new doctors in handling conversations and consultations with parents? And what has been the most helpful quality or aspect of being a pediatrician in your own experiences as a mum?
I think realistically, when you've had kids, there's definitely an element that you bring to the table that you didn't have before. And you'll only ever know that after you've had kids and you do your parenting. So I'm not going to say it was, it's there is a difference. And I think, being a parent does give you insight that I probably lacked before. But to be honest, the gap where I kind of took time out of medicine and really spent so much time with other parents and that really probably that made a big difference to me being a pediatrician. So not just parenting my own kids, but seeing other parents and what they went through and kind of how they navigate the NHS. Because I think, from our perspective, before, we think, oh, it's really easy because we know about the NHS and we know how to navigate the NHS. Actually, parents do not know how to navigate the NHS. And parents who have children who are sick or have complex needs, they just need a lot of support to navigate this crazy system that is not really that conducive or easy. So, I don't, that looking back, probably I could have done that before I was a parent, but I didn't know that that's what they needed. So maybe, just thinking about that aspect of it, what is it that you can give them? Well, you can give them an insight into how the NHS works. You can work out things that, navigate it quite a lot for them, show them the pathways and how things work. You don't have to be a parent to know that, but just understand that they may, the way the NHS sometimes works is really unfathomable to people. So I think anyone can do that. I think that's your skill. And then just being honest and like listening and actually just being honest and saying, I don't know the answer. I think that's absolutely fine. I don't know the answer, but I'm going to go and ask someone else. They don't mind that as long as you're honest.
Yeah, absolutely. That's a really lovely reflection. But unfortunately, that's all we have time for this episode. I think that was such a thought-provoking conversation. So huge
Thank
thanks
you.
again to Dr.
Thank
Ella
you so
for
much.
sharing your insight, experience, and passion for supporting young people.
Thank you so much, Dr. Ella.
Thank you. It's lovely to meet you both, and well done on doing this fantastic new initiative. I think it's brilliant. So keep up. Hopefully see you in Community Paed soon.
Thank you.
Absolutely. So, if you're a medical student interested in community pediatrics, we really hope that this episode gave you some food for thought. And we would love to hear your thoughts, your feedback via Spotify or Instagram. If you liked what you heard, please make sure you're following at teddytalks.peds on Instagram for updates on when episodes will be released. Please rate this episode on Spotify and share.
Thank you for listening to Teddy Talks and see you next time.
Bye bye.